Thank you, Avatar, for introducing me. I do hope that's whetted everyone's appetite for the next 90 minutes. In my turn, I'd like to thank you all for joining us. I understand over 500 people are registered, many from the clinical sites for the AVATAR2 trial, and many, many others in the UK and overseas. Welcome, everyone. Please give me just a moment to open up my slides. I'm going to do an introduction, and I'd just like to introduce you to the programme before I give a brief talk about the background of the AVATAR2 trial. After I've spoken, we will have, I'm delighted to say, introductory talks by Sir Norman Lamb and Dr. Lisa Cameron, MP. After that point, Mark Huckvale, who's designed the technology for the AVATAR studies, will give a demonstration of that technology. Tom Ward, our trial therapy coordinator, and Susie Syrat, our Glasgow-based peer researcher, will demonstrate how AVATAR therapy works in practice. Clem Edwards, the trial coordinator, will then unveil the details of the AVATAR2 trial and describe who may be eligible to take part. We'll then have a brief comfort break, just 5 minutes, and then a panel will be able to take questions and provide answers. So please pose any questions using the Q&A function. The panel will include trial leads from across all the trial sites that will be running. So first, what is AVATAR therapy? I know that many of you will know what it is, but for those who don't, it's a new talking therapy which aims to reduce the distress that can be experienced when hearing voices, using an image or avatar of the distressing voice on a computer. This was the brilliant idea of Professor Julian Leff, then at University College London, and he conceived the idea of bringing an image of the voice by computer into the therapy room. And he worked with Mark Huckvale at UCL to create the software for this. Julian is now retired and living in South Africa, but the wonders of remote access mean that I think he's joining us today for this launch event. So a very warm welcome, especially to Julian Leff and any members of his family that may be joining us. I won't say more about the therapy or the technology because you will have introductions to those in just a minute. But I do want to just give you a very brief overview of the research background that's brought us to this point and has led us to have the case for this trial. The first main study was a proof of concept study led by Julian at UCL and funded by the National Institute of Health Research. This was a small trial of 26 participants, all of whom received the therapy, and it had very exciting results, reducing the frequency and distress of the voices people experienced. It was published in the British Journal of Psychiatry in 2013 to huge excitement and acclaim. The results were so exciting that people felt that there must be something really radically new here that was worth taking forward. So this led on to the first fully powered randomized controlled trial that was led by Tom Craig at KCL, King's College London, and I was also pleased to be involved. This was funded by the Wellcome Trust and took place just at one main site, the South London and Maudsley Trust. 150 participants were allocated between AVATAR therapy or supportive counselling, just 6 or 7 sessions of each. And the results were again very positive. It replicated the findings of Julian's study in showing a real reduction in the severity of voices after therapy at 12 weeks, both in frequency and in distress, as before, with effects generally greater than those we find with existing therapies for distressing voices. So once again, this led to great excitement when published in 2018 in Lancet Psychiatry, and it was clear that further work was indicated to establish evidence and of sustained benefits and across more sites. So that's led us to this point, a multi-site randomized controlled trial, AVATAR2, led by myself, with Tom Craig involved at King's College London, funded by the Wellcome Trust again, and this time we've amassed fantastic teams in universities and NHS settings in Glasgow, Manchester, North and South London. Our aim is to optimise the therapy based on the learning from the previous studies and to examine two forms and consider their effectiveness in a wider variety of settings. If effective and indeed cost effective, this would prepare us well to implementing the therapy widely across many clinical settings. Much more information is available on the AVATAR website. But first, I particularly want to introduce the 4 teams at the clinical sites which will be recruiting participants into the new AVATAR trial. If you go to our website and enter avatartherapytrial.com, you'll come to the home page, and then you can go to People and Contacts and click on the team, and then you'll find these 4 sites. In Glasgow, the site is led by Andrew Gumley and Hamish MacLeod, and the first trial site is Greater Glasgow and Clyde. In South London, it's led by myself and Tom Craig, and the first site will be the South London and Maudsley Trust. In North London, the site is led by Miriam Fornells-Ambroho, and the first site will be the NELFT Foundation Trust. And then in Manchester, led by Jill Haddock and Sandra Bucci, the first site will be Greater Manchester Mental Health, and also Penine Care coming on. There's lots more information about the great teams at each of those sites, and also about our various collaborators, statisticians, health economists, experts in experience sampling, monitoring, and experts in therapy, all of whom are working with us to make this trial work. On the website, there's plenty more information, and my final element of this presentation is just to give an overview of the trial, which would be the overview that potential participants would see, or clinicians finding out about taking part in the trial. And so that's just to give you this context before we go on to more detail in the following presentations.
People from all walks of life hear voices that others around them cannot. For some, the voices become distressing and start to get in the way. Avatar therapy aims to help people who hear distressing voices. The person starts by creating their own avatar with the therapist using a computer. The avatar looks and sounds like the voice they hear. The person learns to stand up to the avatar and take control in a calm and confident way. The therapy can also help the person to understand their voice and to enjoy life more. This is John's experience of having the therapy.
I found the avatar therapy a real game changer. It enabled me to stand up to the voices in a non-aggressive way and reduce the intensity of them. The voices became much more manageable for me and easier to deal with.
In the Avatar trial, we're trying to find out how many sessions of this therapy is most helpful. Taking part involves first meeting with a researcher to discuss how things are going. People then follow one of 3 paths chosen at random. On the first 2 paths, people will receive either 6 or 12 sessions of avatar therapy. On the 3rd path, the person continues with their current support. Everyone then meets with the researcher 16 weeks and 28 weeks after the first meeting and receives £20 for each of these research meetings. Each path is equally important in working out whether avatar therapy makes a difference to people. We will also offer this therapy to those who do not receive it during the trial. By taking part, you will be helping us improve the treatments we can offer to people who hear voices. This trial is funded by the Wellcome Trust. As part of the trial, we're looking to make the therapy available more widely in the NHS. If you experience distressing voices, or know someone who does and would like to find out more, here's how to get in touch.
I do hope that's whetted your appetite for what is to come, and do remember to post any questions on the Q&A. And now I'm really delighted to introduce to you Sir Norman Lamb. He is the chair of the South London and Maudsley Trust and a great campaigner for mental health. Previously as an MP and health minister, he made a huge impact on mental health policy and provision, working to achieve equality between mental and physical health. And he introduced the first standards which set in stone that people with mental health problems should have as much a priority given to access to treatment as people with physical health problems. So I'm delighted to hand over and welcome Sir Norman Lamb.
Thank you very much indeed, Philippa. Very kind introduction. I should also say, incidentally, that it's great to be talking alongside my ex-colleague Lisa Cameron, MP. We spoke in many debates together in Parliament, both making the case for improved support for people with mental ill health. So it's a great privilege to have been asked to speak at this event. And I suppose what I would say is that the remarkable audience, over 500 people registered for this event, for me is a mark of the significance of this research trial. And in preparing for what I was going to say today, I was reflecting on the fact that over the last few years we've made significant progress in reducing stigma for many people who experience mental ill health. But for the group of people that this trial seeks to support, those who have persistent distressing voices, they still suffer extraordinary stigma. And if we're honest, healthcare has not had an enormous impact hitherto on their quality of life and on their experience day to day. And so this trial and what we have learned so far of the use of avatars, I think is, as you heard in that little video clip, potentially a real game changer. I had an absolutely fascinating conversation with the team last week, and I should incidentally pay tribute to the remarkable and brilliant group of people who have led the work on this. And I was very struck by both the number of people who could potentially benefit from this therapy, running into thousands of people, about half, as I understand it, of those people who experience schizophrenia. But I'm also struck by the extraordinary potential positive impact on those people's lives. And I remember hearing from Professor Tom Craig about one man who couldn't visit shops because of the voice in his head, but after this treatment was able to visit shops again, was in a sense liberated by this treatment. And there will be some people, we already know, who completely sort their problem of hearing voices. They no longer hear voices as a result of this. This is a small minority, but for about a third of people, the impact is very considerable. Now, this opens up so many possibilities for people. It opens up the possibility of employment, but it potentially transforms people's lives, giving people the chance of a good life, a happy life, which the rest of us take for granted. I was delighted to hear also that the therapy will be used for those people who are benefiting from early intervention in psychosis treatment. I introduced the 2-week standard in England for those people who experience a first episode of psychosis. And for those people who continue to experience persistent voices, this therapy in this trial will now be trialed to see what impact it can have on those people. And we're also, as I understand it, will be looking at cost effectiveness. Paul McCrone, I understand, will be part of that work, or will lead that work, critical in convincing commissioners that this is a therapy that is worth pursuing. And I understand that the whole purpose of this trial, this randomized controlled trial, will be to produce evidence strong enough to convince NICE to issue guidelines, which would then make it widely available. Now, there's the whole issue of building a workforce in order to be able to deliver this therapy. But it's fascinating because with just 4 sessions, as I understand it, for many people, it can have life-changing consequences. And so the cost of this therapy is potentially low cost, which means that it is of enormous potential benefit to the healthcare system as a whole. So when you have low cost with a substantial potential impact on people, with thousands of people potentially benefiting from this, you can see just what a game changer this therapy could be. I'm immensely excited that the first trial was at the Maudsley. It's now fantastic that it's going to be taking place in 4 centres in Scotland, in Glasgow, Manchester, and in 2 centres in London. I'm so excited by the potential of this. So good luck to everybody, and thank you so much for giving me the opportunity to offer some reflections this afternoon.
Thank you so much, Sir Norman, for that really encouraging introduction to our live event. It's wonderful to have your support, the support of the South London and Maudsley Trust, but also that recognition that this is about trying to improve the lives of people who haven't often had adequate treatment. I'm now delighted to introduce Dr. Lisa Cameron, MP for East Kilbride, Strathaven and Lesmahagow. She is also, very unusually, a consultant clinical psychologist. She chairs the All-Party Parliamentary Group for Health and is the party spokesperson for mental health. And I know that in Parliament she is working as a great advocate for mental health and indeed for the role of psychology. So we're really delighted that our trial is taking place also on Lisa's patch as well as local to Norman, and I'd like to welcome Dr. Lisa Cameron most warmly.
Thank you so much, Philippa. It's an absolute pleasure to be here today and to follow on from Sir Norman's excellent, eloquent introduction alongside yourself. And I think, you know, we all miss you, Norman, in Parliament because you have been such a fantastic advocate for mental health, and are just delighted that you're continuing to work on mental health issues to help communities and members of the public at such a high level. So real privilege to be following you today and to be speaking about this excellent, innovative, you know, I'm saying innovative because my days as a clinical psychologist seem a bit far removed now, but who knew we were going to have avatars as therapists or involved in therapy? So that's definitely something that I'd have to be getting up to speed with. But it's a delight to be speaking today, to be hearing about the progress that's being made, and particularly in relation to helping those who perhaps have distressing voices that interfere in their quality of life and their treatment. And I know from working as a psychologist prior to coming into Parliament as to how distressing those experiences can be for patients, and as to how they can often feel that perhaps they're not in control of their lives in the way that they would like to be. So I think having this type of therapy, which gives individuals the opportunity to engage in a positive and safe way with a therapist and with the avatar, to challenge the voices, to learn to feel more in control, and to be able to stand up to those voices and to try to improve quality of life, and also coping strategies that will last over the long term in relation to, as you know, we'd heard, perhaps schizophrenia. Also, I'm thinking about the types of negative voices that people have when they're feeling very depressed and self-critical, and also in anxiety conditions, perhaps, whereby individuals are hearing voices undermining their self-confidence, perhaps thinking very anxious thoughts, catastrophic thoughts, and also being able perhaps to use avatar type therapies in the future for all of those types of conditions if things are able to be taken forward in the AVATAR2 trial and then rolled out in the future, which I'm really hoping will happen in relation to the NICE guidance, as has been mentioned. I declare an interest, as has already been mentioned, in that I'm an alumni of Glasgow University, so I'm extra delighted that one of the sites will be at Glasgow with Professor Gumley, who I recall very fondly from the clinical training as always being a pioneer in much of the work and the research that was taking place, and alongside the clinical psychology course there, and obviously with Professor Garrity leading up on this and the involvement too of Manchester. I think it will be a real across the UK approach that could help so many people in all of our nations, and I'm so pleased that that's the situation and the excellent work that's going to be taken forward. Now in Parliament, we are also advocating, as Philippa had mentioned, for psychosocial approach, to be looking at models like the AVATAR therapy, to be making sure that patients have not just a medical model in response to mental health, but also very much a psychological model, and one that helps them in terms of their long-term coping strategies in that aspect control. And the Psychology All-Party Group has been established from the 2017 election, a cross-party group that I'm really privileged to chair, and very, very pleased that we're going to be having a session in the near future where we speak more so about AVATAR and hopefully have cross-party MPs and peers from our House of Lords to learn much more about AVATAR2 trial and the therapy, and to be introduced to the technology as I have been in the past few weeks. The other work that we're going to do to support the trial is we're going to put together a cross-party early day motion to highlight the trial to legislators and the important work that's already been completed and the work that this hopes to take forward for the future. Because as MPs in Parliament, we're really there to support people to get the help that they need. And mental health, I feel, I'm so proud to be in Parliament just now. I'm sure if I had been elected maybe 20 years ago, mental health would still have been very stigmatised and an issue that wasn't discussed. But now, through the work that Norman has been doing in Parliament over such a long period of time, through work that other MPs also have been contributing to, I think of Paula Sheriff, who did excellent work as the Labour mental health spokesperson in the last Parliament too. It's a real cross-party effort, and we'll be able to ensure that mental health is a priority moving forward through both the mental health and psychology all-party groups. So I'm looking forward to hearing so much about AVATAR therapy, about the impact it's having, about how we can help to support this innovative technique going forward. I was one of the CBT for psychosis trained therapists in Glasgow, so I now feel that I'm going to be upping my own skills too by listening to today's session. But again, I'm delighted to hear about it. It will make a difference, and you have all my support moving forward in terms of the cross-party work that we're doing in Parliament to promote mental health and innovative techniques just like AVATAR2, as we heard today. Thank you.
Thank you very much, Lisa, for your wonderful and encouraging talk, and fantastic to hear that you're working so well in Parliament around the topic of mental health, and even that there may be an early day motion about the AVATAR2 trial with cross-party support, and also we would be delighted to come and offer anything we can to parliamentarians in terms of understanding how AVATAR and new technology may contribute to people's mental health. So thank you so much for your encouragement and support. And I would now like to introduce Dr. Tom Ward, who is a clinical psychologist and researcher at King's College London and the South London and Maudsley Trust. He is the overall therapy coordinator for this trial, training everyone in delivering the therapy, providing some of the therapy, and he is the absolutely perfect person for this role, having already worked as the lead therapist in the AVATAR1 trial. He knows more than most of the rest of us about the therapy. So I would like to hand over to Dr. Tom Ward, who is going to start with an introduction to the AVATAR therapy.
So thank you very much for that introduction, Philippa. And also just to say I'm extremely happy and proud to be speaking to everyone on behalf of the AVATAR therapy team today. We're going to start this, we're going to now bring the AVATAR therapy into focus, and we're going to start this section with Professor Mark Huckvale, who's going to provide a demonstration of the AVATAR therapy software.
Hello, my name is Mark Huckvale, and I'm the designer and developer of the AVATAR technology that the clinicians use to provide AVATAR therapy in practice. In this demonstration, I'd like to show you some of the capabilities and functionality of the system. On my left, you can see an example avatar. It's a three-dimensional computer model of a head with an appearance that can be chosen by the user. This avatar has been modeled on my face. The head is animated, as you can see, to make it look as though the head is talking, with the lip movements synchronized to the speech that it's producing. The avatar system is extremely flexible, both in the choice of the face of the avatar, but also in the characteristics of the voice, as I'd like to show you now. We can change the face of the avatar very easily. For example, here is a different male face, and here is a female face. We can change the age of the face. Here is a young person, and here is an older looking person. We can also choose avatars of different ethnicities, like this face, for example, or a face like this. As well as changing the face of the avatar, we can also change the voice of the avatar. For example, I can now lower the pitch of the voice coming out of the avatar so that it sounds like it's coming from a much larger person. I can also change the size of the vocal tract of the person that's speaking. And so now the avatar sounds as if it's coming from a much smaller person. I can also change the breathiness of the voice and make it more and more breathy until it turns into a whisper like this, with a whispery voice quality. The avatar system runs on ordinary laptop computers that connect the therapist to the patient either locally within the clinic or remotely over the internet. The avatar system is registered with the Medicines and Healthcare Products Regulatory Agency as a medical device that can be used in clinical practice. That's the end of the demo. From my avatar and me, thank you for watching.
So thank you to the two Marks for providing that insight into the capabilities of the AVATAR software. The work of Mark and his colleagues provides us therapists with a unique opportunity by bringing the voice into the heart of what we're doing in the therapy. In AVATAR therapy, we're looking to connect with the lived experience of hearing a voice from the very first meeting. So with that in mind, we're now going to hear from Susie Syret, our brilliant peer researcher based at the University of Glasgow, who provides a lived experience perspective on what it means to hear a voice.
Hi, I'm 47 and I've been living with a voice since my early 20s. The voice is always faster and smarter than me. It's constant and always undoes anything positive that I might be feeling or that someone might have said about me. The language it uses, it's horrendous. It's incredibly abusive and just foul, to be honest. It keeps me awake at night and it distracts me when I'm trying to concentrate on anything that I want to focus on. It second guesses and it undoes and undermines everything that I might be feeling. The voice loves to pour on guilt. When I'm not feeling well, but even when I'm feeling better, it likes to tell me that people wish I'd just go away, that I don't deserve sympathy, and I certainly don't deserve any help. In fact, it makes calling for help really difficult sometimes. When I should probably be speaking to my CPN, it tells me that she just wants rid of me, that I'm a waste of time, and that her time would be better spent caring for other people. Living with a voice like this is really hard. I wish to God I didn't have it. It would be so much easier to live in silence.
So thank you so much to Susie for sharing her experience and illustrating so powerfully the different ways in which a voice can impact on a person's life, and in particular the ways that a voice can isolate someone from other people. The challenge for any psychological therapy is how do we bring this deeply compelling personal experience into therapy in a way that's valid and helpful for the person. And it's here that the inventor of avatar therapy, Professor Julian Leff, had the insight that we could use avatars as a representation of the person's voice. As we've heard from Mark, an avatar is created with the person to match the main distressing voice that they hear, matched both in terms of how it sounds and how the avatar looks. The success of the software means that we have the emotion online in the therapy. It's a valid representation for the people that we see. It's part of the power of the avatar therapy approach, but it means that we need to approach this as therapists with care and consideration of the person. During the previous avatar trial, there was no evidence of any adverse events that were related to the therapy. But we as therapists will never underestimate what we're asking people to do in the therapy. Coming face to face with experiences that can be associated with intense feelings of fear, of hopelessness, of anger, and for some people, feelings of shame. As therapists, what we're trying to do is build a relationship with the person, provide a safe context where they can speak truth to the voice in a way that may feel daunting at first, but carries the potential for powerful change. Each avatar therapy session lasts 60 minutes approximately and starts with a discussion with the therapist. The voice is discussed and the week is reviewed, and the person plans and practices what they want to say to the avatar. We then move into the active dialogue part of the session, and at that point the therapist is in a separate room but can see everything that goes on through a webcam. The person can also talk to the therapist at all times. Early dialogues tend to be relatively short at around 5 minutes, but this increases to around 10 minutes over time. Each dialogue is recorded and the person gets a chance to listen back to their dialogues during the week. Following the dialogue, there's a debrief during which there's a chance to acknowledge the important things that the person has managed to say. And this is a chance to consolidate a sense of increased power, control and confidence, which are the guiding principles of avatar therapy. In the previous trial, it was striking that people were reporting significant improvements, sometimes after only a couple of sessions. As therapists, we didn't feel that we'd done anything particularly sophisticated at that point. Rather, we just delivered a realistic enactment of the voice and supported the person to respond assertively to the avatar. Therefore, in the current trial, we're testing a version of the therapy which is brief and delivered over 6 sessions. The focus of avatar therapy brief is on supporting the person to stand up to their voice as the avatar as it delivers the same hostile and abusive content that they hear from their voice. The use of the voice content is important because people frequently describe feeling experiences of feeling trapped and powerless in the context of their voice. What we're looking to try to do in avatar therapy is change that relationship so that over time the person develops an increased sense of power and control in the dialogue. We hope, of course, that this generalises to the voice in daily life. Avatar Brief is delivered following a standardised treatment protocol. It's relatively straightforward to deliver, and this is really important because if the AVATAR2 trial finds that this is an effective intervention, it's relatively easier to implement this Avatar Brief version. In the next clip, Susie and I demonstrate what an early Avatar session looks like. So hi Susie, we're going to start in a moment. Can I just check how you're feeling?
I'm ready to go.
Okay, great. Just remember, the main thing today is just to stand up as confidently as you can. Just tell them that you're not going to put up with this abuse anymore and that you're in control, just like we practiced. So I'm going to switch across to the avatar, but just remember that I'm here at all times and you can talk to me at all times as well.
I'm ready to go.
Don't go and see your friends today.
They hate you. They're laughing behind your back.
They invited me. I think I should probably go.
Hi Susie, that's a really good start. Just want to check in with how you're feeling.
Okay, a bit shaky. It's tough.
Yeah, I know you're doing really well. I know this is tough. Just when he comes in with that abuse again, just as strong as you can, maybe just sit up in your chair and look him in the eye and just tell him how it's going to be.
I've got this. Yeah, okay.
Don't go. You'll just embarrass yourself.
No, sod off. I don't care what you say. They're my friends. I'm going to go anyway.
Hi Susie, that was really brilliant there. Really showing him that you're calling the shots and you're in control now. Really well done. For other people on the AVATAR1 trial, the positive change was less about this early assertiveness work and seemed to happen in later sessions after the avatar had transitioned to a less hostile position and the dialogues were more involved around personal themes. So in the AVATAR2 trial, we're also testing an extended version of the therapy that's delivered over 12 sessions and comprises 2 phases. The first phase mirrors exactly what I've just described in terms of the Avatar Brief intervention. The additional sessions allow us to develop dialogues that are more personalised. They're guided by an individual formulation. This is essentially a collaborative understanding of the voice that seeks to locate the voice in the broader context of the person's life. It's a sad fact that many of the people we see have experienced trauma and abuse. For some, the dialogues become an opportunity to develop an understanding of how these experiences have impacted on their life and how they may have become manifest in the experience of hearing a voice. For other people, the dialogues are less about the past and more focused on how the person wants to approach daily life and engage with the things that matter to them. Avatar therapy, the personal meaning that's associated with the voice is central to everything that we do. We're looking for the person to develop ways of understanding their voice where it becomes less threatening, less powerful, and less negatively impactful on their life. The way in which the person views himself is also central, and there's a consistent focus on building self-esteem and developing self-compassion. As Susie's discussed, voices can get in the way of people connecting with others. As Sir Norma's also mentioned, there remains a hugely damaging societal stigma around the experience of hearing voices. Voice content can reflect experiences of discrimination, marginalisation, and social exclusion. So for some people, the dialogues become an opportunity to positively voice their own identity, to challenge discrimination, and to map out relationships which are not defined by the past, but guided by the new and emerging sense of themselves. Delivering avatar therapy is often a humbling experience. We witness people deliver powerful and moving statements to their voices. We see people break patterns of silence and shame which may have been part of their lives for many years. We started this section from hearing from Susie a lived experience perspective on what it is to hear a voice. And we're now going to finish with Jane, who provides her experience or shares her experience on what it is to receive avatar therapy.
I would like to say, since I've been unwell, I have had many psychological therapies. I can honestly say that avatar therapy has helped me the most. Listening back to the MP3 is like having therapy in my pocket. It has helped me gain back control of the voices. Being face to face with the avatar was very hard for me at first, especially the first session, but after a while I became more confident. It was easier for me to talk back to the avatar. At times it was very challenging, but I was very well supported during all of my sessions. I think it's hard for people like me to try new therapies, but it has helped me so much in my recovery.
So thank you to Jane and thank you to everyone for listening. I'm now going to hand over to Clem Edwards, who's the AVATAR2 trial coordinator.
Thank you, Tom. I'm absolutely delighted to be here sharing with you all the details of the AVATAR2 trial. Just give me a second while I make sure my slides are in the right place. So as you probably already gathered, this is definitely a team effort, and I'd like to thank Tasha and Steph for all their help putting these slides together as well. So I'm going to move on to talk to you about the aims of AVATAR2, and the first one of these follows on nicely from what Tom's already discussed. We want to make AVATAR therapy as effective as possible, and AVATAR2 offers many opportunities to look at the different components of AVATAR therapy and make each one as effective as it can be, as well as understanding who it will work best for, and I guess ideally the combination of which bits will work best for which people. We are looking at two forms of AVATAR therapy, as Tom's already described, brief and extended, and we'll be comparing both of those to treatment as usual, which, as Philippa mentioned, is the next step, having used an active control of supportive counselling in AVATAR1. Crucially, for getting AVATAR therapy more widely available and that all-important NICE recommendation, we hope to establish that both brief and extended AVATAR therapy are cost-effective interventions for people who hear distressing voices. We can't wait to meet new therapists who are interested in learning AVATAR therapy and helping us make it better, and also in learning how to train them. As Philippa mentioned, we've done one study in South London and Maudsley NHS Trust so far, and we're so excited to be going to more trusts and meeting more people. We hope to train over 20 therapists by the end of the trial. Using these manuals and our understanding of training alongside the software that Mark so helpfully explained clearly in his video earlier, we hope to have a combined technical and clinical support package that we can offer to NHS services at the end of AVATAR2. So what does AVATAR2 look like? Well, when we receive a referral for someone who might benefit from the therapy or be interested in taking part in the trial, we'll meet with them initially to conduct a baseline assessment. So that's our first meeting where we take them through the measures and interviews and questionnaires that we're using. Our participants will then be randomised, and this is a randomised controlled trial. So randomised means that kind of like flipping a coin or done by computer, will decide which of three options someone will go into. Whether they receive 6 sessions of AVATAR therapy, so the brief version that was mentioned earlier, 12 sessions, the extended version, or treatment as usual, so their usual care and support that they're receiving from any mental health services at the moment. Someone entering AVATAR2 has initially a 66% chance of receiving therapy as part of the trial, because they have an equal chance of being in each of these 3 arms. So 2 arms have therapy in them. But we're really pleased to say that because we're training so many therapists, we can offer everybody that takes part in AVATAR2 in the treatment as usual arm therapy at the end of their participation. When someone has completed the treatment part of the trial, we meet with them again at 16 weeks to complete some follow-up measures to see what effect the therapy has had, if there's been any change in the treatment as usual group as well, so that we can compare that. And then we do that again at 28 weeks to see if that is the same after a bit more time has passed. So in total, someone will be in AVATAR2 for approximately 7 months. I'd just like to outline the kind of people that we think would be would get a lot out of this trial and would perhaps benefit from the therapy. But obviously our main message is, if you're interested, or if you know someone or work with someone that might be interested, please talk to us about them and or yourself, and whether it would be good for you to take part. So we're looking for adults We're looking for people under the care of a mental health team. So it doesn't have to be any special type of mental health team, just some support for their mental health beyond what a GP might offer. And that's just to ensure they can take part safely. We would like to speak to people that have heard a distressing voice for longer than 6 months, and associated with that have received a psychotic disorder diagnosis, or things that get called psychotic disorders, or affective disorders with psychotic features. This covers a range of different labels that are used, but might refer to things such as schizophrenia or bipolar disorder. The primary outcome, so the thing we're most interested in having a look at in AVATAR2 and seeing if we can improve it, is the distress people feel associated with their voices. And we use an interview measure called the CIRATS Auditory Hallucination Scale to do this. It's important to say that this was the same outcome as in AVATAR1, and we want to see if we can replicate this finding in a bigger study. As Tom and I have both said, we're really interested in how this therapy works. And what we know from AVATAR1 is 2 key themes that might be important are the sense of power and control someone has in their relationship with the voice that they hear. And if we can increase that sense of power and the sense of control, maybe we can improve the distress they hear, so the distress they feel, sorry. So we're really interested in those themes of power and control. We're also really interested in anxiety, and our colleague, Dr. Marus Calafé, recently published a paper showing that how anxiety change during AVATAR therapy was a really important indicator of whether someone would do well in the therapy. In AVATAR2, we're taking this further, and we're not only measuring anxiety in therapy sessions, but we're also looking at anxiety and other factors in everyday life using a technology or an approach called experience sampling methodology. I'd like to hand over to our colleagues at the University of Leuven and a video they put together to explain this approach.
The experience sampling method, or ESM for short, is an intensive data collection method that uses smartphones to assess mental states and human behavior in real time. We thereby actively collect data by notifying participants on their smartphones, asking them to fill out a questionnaire multiple times per day for a number of days. So why use ESM and not something else? Well, imaging, genetic or clinical interviewing methods do not study psychopathology in the context of everyday life. Instead, people are questioned or studied in a closed and safe environment. But symptoms of psychopathology don't exist in a vacuum. They are dynamic and are influenced by events that occur in daily life. The frequency and intensity of symptoms can thus fluctuate, making multiple assessments more favorable. Human memory is also susceptible to heuristics. For example, we tend to think and talk in line with our momentary affective states. If we are feeling positive, we tend to think and report more positive than negative events. When we're feeling down, it's the other way around. Given this, it's not hard to imagine that only single assessments can lead to tremendous misperceptions on symptomatology, treatment compliance, undetected side effects, misdiagnosis, or even drug approval. ESM also has the potential to empower patients by actively involving them into the treatment process, as well as providing them insight into their own dynamical patterns of mental states and behavior.
So thanks again to our colleagues at the University of Leuven who are collaborating with us on this approach, and we're really excited to see the impact of AVATAR therapy in daily life. Here's a graph that just illustrates how that might work in AVATAR2. So we're asking people to complete the questionnaire 10 times a day, and we'll be asking them each time if they are currently hearing their voice, if their voice is not present, or if they're thinking about their voice. And you can see here in this graph across the bottom is the different questionnaires someone's completed during the day, and up the left-hand side is how stressed they reported that they were feeling at that time. And the different colours show you whether the voice was there or not. So just in one snapshot, we can see that it's not just whether the voice is there or not that decides whether someone is stressed. They've said they're feeling a bit more stressed when the voice is present or not present. So we can understand a bit more the details of these relationships and how they might change, and even more excitingly for us, whether AVATAR therapy makes a difference. Patient and public involvement, or PPI, is central to all we do in AVATAR2, and we're really pleased to have a PPI reference group already set up in the trial, and you've heard from our peer researcher Susie, who's been leading on that as well in Glasgow. I just wanted to share a little bit about how it's going to be involved going forwards. We ask our PPI reference group lots of questions, but I guess the general theme is how can we make this trial a success? And success is measured in lots of ways: reaching the right people, ensuring they have a positive experience of research, and delivering therapy in a way that's accessible and beneficial to the people we work with. We're going to be asking people about their experiences of avatar therapy using qualitative methods, and we've asked our PPI group to support us in developing that process. They also help us spread the word and, like I said, ensure we reach the right people. And I'm sure we have many more directions to go in that we haven't thought about yet. I just wanted to share one of our experts by experience thoughts on what it's like to be involved in a PPI group in a trial from SLOMO, which was run in the group previously, a trial of a different psychological therapy. In discussion with her, it was decided that a member of our team would read her words for us.
Overall, my experience of delivering PPI work has been empowering. I feel I have gained knowledge and insight into growing an idea to help people with similar experiences to myself. Being actively part of the team and process, working alongside the mental health professionals leading the project, was mutually beneficial and helped influence and improve the way ideas were executed. Lastly, and most importantly, I feel that the opinions, thoughts and feedback I voiced has added what would have been missing input from the perspective of someone who this project is aimed at helping. I've personally gained new transferable skills, improved on existing skills, and built up my confidence.
So even more reasons there that PPI is at the centre of our work, and thank you to our colleague for sharing her thoughts with us. We've managed to make it this far without talking about it too much, but obviously we must reference the pandemic and our preparations for that. We have approval to conduct all our processes remotely, including therapy, which can now be delivered via a secure video calling software system, entirely down to the hard work of Mark Huckvale. Our policy is to work flexibly and most importantly in line with our university partners and NHS Trust guidance to deliver the trial safely, and we'll be doing that as the times change and the situation changes throughout AVATAR2. So I'm just going to finish by letting you know what we hope to have got to at the end of AVATAR2 and what we hope to be able to share. We hope to have avatar therapy software optimised for use in clinical settings, not only in South London and Maudsley NHS Trust, who are so grateful for supporting us again, but in new partners and with new therapists sharing their ideas with us as well. We hope to have shown that Avatar Brief and Avatar Extended are effective interventions for the distress associated with hearing voices in a large multi-centre study, and that can be maintained to the 7-month follow-up. We hope to have shown they're cost-effective interventions that can go on, can be NICE recommended, and that will really ensure we can take Avatar therapy to more people. We hope to have a sense of how to train others successfully in avatar therapy, to have manuals that support that process, and most importantly of all, lots more avatar therapists out there in the UK that can bring this to the people that need it. If you would like our team to come and present to your team or to a group that you're working with, please let your local team know. All the details are on the website there. And I'm really delighted to say that we are open for referrals, so please get in touch. Thank you for listening to my details of AVATAR2 today. We're going to have a short break now for 5 minutes, and I look forward to the questions that you put to us, and the panel will address them at 4:35. Thank you very much.
Hi everyone and welcome back. Thank you so much for joining us. And we've had some really interesting presentations and we're delighted that we've been able to share more with you about our trial and about the therapy and the software. And we've had some really interesting questions coming in as well, so thank you very much for those. I suppose we've had a range of different questions, been quite a few questions about the therapy, and I suppose maybe one that might kind of start to get the ball rolling is maybe to ask Susie Serrett, who's on our panel, you know, as someone who hears voices yourself, how how does it feel to have your voice represented in this way?
It felt at the time, I was quite anxious, as I think is understandable, but you know, having tried sort of empty chair sort of therapy with a psychologist, and finding that really challenging and really difficult, in that the voice I hear sort of feels amorphous and it's everywhere. It was very difficult for me to contain a voice down into that chair myself. So actually something that was really helpful and reduced my anxiety a lot was seeing this voice in a format that was reduced and contained within a screen. It was literally separated from me by a screen, and it gave me immediately a feeling of much sort of lower threat, but also that, you know, maybe I have a bit more control here as well. And, you know, that coupled with the fact that, you know, clearly a therapist is engaging with me in a way that shows that therapist absolutely believes I hear this voice, because there's always a slight doubt that other people actually believe you hear something all the time, because you can't share it with anyone. You can't, you know, enable anyone else to experience what that feels like and how constant it is. So this was also sort of legitimizing and validating that, yeah, this happens, and, you know, a therapist and an avatar therapy is here to address that and help. Just to mention, I saw a question from somebody asking, what if a participant's voice isn't associated with any physical representation? I would say I definitely fall into that bracket, but I found it surprisingly easy to create an avatar. Obviously, I know what the voice sounds like, so that was pretty straightforward. But, you know, there's a lot around expression and the sense of dominance that it has that actually made choosing its physical form quite easy. Which was something I was surprised at. But having had, you know, literally one experience, as you saw on the video, of having avatar therapy, I think what's been really interesting for me is to reflect back on it and realise just how much in that time frame my anxiety around the voice I hear has reduced, and how I feel I can visualise it now in a safe and contained way. And that's been very helpful to me, you know, just on a personal level.
Thanks so much, Susie. That's really interesting to hear. So as you can probably see from the questions that have come in, you've all up-liked a lot of them, so we're just going to have a bit of a discussion around some more of the questions, but I think that was really helpful to open up conversation and thinking about the therapy and you know, how that's experienced. So one of the questions that we have is, have the studies included people whose voices are previous perpetrators of abuse rather than unknown voices? And have there been any cases where there have been re-traumatization? So I'm wondering if that might be a good question to pose to Tom. So Tom, if you have any response to that question there?
Yeah, thanks very much, Maura. There's two questions there, isn't there? The answer to the first question is yes, very much so. There have been times where the person's voice has reflected experiences of abuse and perpetrators from the past. And in some ways, some of the most striking sessions have been in that context. You know, can remember somebody, you know, speaking to a voice that represented her father, who was a dominant and abusive character in her early life, and being able to say things to that avatar that she would never have felt able to say to the voice, to her father, was something that was really extremely powerful. So there were a number of different examples, but the answer to that question is yes, very much so. There's no evidence of any sense of re-traumatizing, and it's actually quite the opposite. As I said in my talk, we don't underestimate what's going on in the therapy, what we're asking people to do, and there can be anxiety and it can be difficult, particularly the early sessions. But the typical experiences of somebody at the end of those sessions feeling or describing a sense of liberation, and very much that sense of empowerment that Susie's just mentioned, that's the way in which most people are experiencing the therapy. But of course we do sort of take very much care of that. I'm just wondering if Tom Craig may have something to add just on the back of that, as someone else who delivered a lot of therapy on the trial.
No, I think you said it all, Tom, really. I think I was really worried that there would be some leakage of the experience out into people's lives outside of the therapy room. And in fact, there wasn't. We saw none of my feared ill effects were manifest in any of the participants we had. indeed quite the opposite, really. That the only instance, I always tell this story, but the only instance of someone experiencing something related to the therapy outside of the therapy room was a man who thought he saw his avatar on a computer in a shop and felt comforted and reassured by that. So very unusual. It was the only experience of something outside of the therapy room.
Thanks very much. I think that's really interesting points that you're making. So there's a few more questions and that are quite close in the amount of likes. So, but there were a few questions that came in that were around diagnostic categories and inclusion criteria, as well as ones around services. So I was wondering if these might be questions maybe for Clem. So there was questions around, would a person receiving input from forensic mental health services, either inpatient or outpatient, be able to take part in the trial? Another question was, is the avatar only going to be made available to those with a schizophrenia diagnosis, or will it be accessible to people with other diagnoses? And there was another question about resources for individuals with learning disability. So I suppose just thinking about like the complex kind of, you know, often complex presentations, but also lots of different diagnostic kind of labels that people might have, and if you've any thoughts on those that might address those questions.
Thank you, Moya. Yes, of course. So to think about people receiving support from a forensic service, either inpatient or outpatient, so there's no reason that would exclude them as long as they met our other criteria. We don't have the ethical framework to work with people who are kind of under the jurisdiction of the Ministry of Justice. So if they were classed as a prisoner, then unfortunately we couldn't work with them. But if they are receiving forensic input as a service user, then that's not an exclusion criteria. And our main thing, and my main response to all these questions, is that we really want to help people who are hearing a distressing voice, that from our experience we think would perhaps benefit from avatar therapy. So we're really keen to talk about people, so and not kind of take a carte blanche approach to these to criteria. So I would apply that to learning disability as well. I know in the previous trial my colleagues worked with people who had some learning needs and adapted the therapy slightly for that. And again, it wouldn't be an out and out exclusion criteria as long as they met the other criteria of having a psychosis or an affective disorder with a psychosis. And the question around schizophrenia being the only diagnosis we're working with, absolutely not, although we do expect to work with a lot of people who have been given that diagnosis in the trial. We're also open to referrals for people with depression with psychosis, first episode psychosis, bipolar disorder, schizoaffective disorder, a range of things really. So please do get in touch and discuss anyone or discuss your own situation with us. I think I would just value the input of Tom Craig on the experiences in the previous trial of working with this kind of diagnosis versus voice hearing experience in terms of who benefited or who we'd like to work with.
Sure. Well, all the trials so far, the previous Julian Left's first work and ours, were focused on psychosis. And so the only experience we really have of successful therapy are diagnoses that fall under the umbrella of psychosis. I know that Professor Leff did have a couple of people with a personality disorder label who didn't do terribly well with therapy. But so I think to answer the question in research terms, we need to keep things reasonably simple. So that's why sticking with a psychosis diagnosis, because we don't want to get sort of sidetracked into an area. Later studies will have to look at whether voices in anxiety conditions or in personality disorders or etc., all the other psychiatric conditions that have voices. It'll take more studies, I think, rather than ours to answer.
That's great, thanks very much. So we've had a lot of other questions as well about the therapy, but one that came in that was more about the implementation, I suppose, was about will this be available in other trusts? So maybe Philippa, or if anyone else on the panel has could respond to that. It says, can anyone from any mental health trust participate, or only people who are under particular trusts?
Thank you, Moya. What I'd like to do is just quickly to flag up that apart from the South London and Maudsley Trust, and then 2 other trusts in South London, Oxleas and South West London St George's afterwards, there will be, as we've mentioned, sites in Glasgow, Manchester and North London. I'd just quickly like to ask Andrew, Gillian and Miriam just to refer to their trusts and the people who could therefore easily be referred to the trial there. Could I just pass it over to Andrew first?
Yes, thank you very much, Philippa. So in Glasgow, our main site is NHS Greater Glasgow and Clyde Health Board, and our plan is then from November 2021 to open up a second site based in NHS Lanarkshire board, and of course that's subject to all the managerial approvals being in place by then.
Gillian?
Hi, thanks Philippa. So we're starting off in Greater Manchester Mental Health and Social Care NHS Foundation Trust, which spans all the way up from the north of Manchester to the south and east and west, so it covers quite a large area. Like Andrew, we will also be starting in a second trust towards the end of 2021, which is Penine Care, which is across to the sort of the right-hand side of Manchester, all the way up from Rochdale down to Stockport. So again, quite a wide area. Thank you.
Miriam.
Hi, thanks, Philippa. Yes, so we're going to start in the North London site in the North and East London Foundation Trust, NELFT, where I'm based. And then, as Andrew mentioned, around November 2021, we'll move to Camden and Islington.
Okay, so I'm going to hand over to Jeffrey now, who's the trial coordinator at UCL, which is where Miriam, who just spoke, was based. And Jeffrey is going to ask the next question, I do believe.
Yes, thank you, Moya. So our next question, we thought we might direct this towards Mark, who's overlooked the development of the software, which is of course crucial to the trial. There's been a few questions about the extent to which the avatar might be customizable. So for example, to what extent you might be able to program it to have facial expressions, and also to what extent you might be able to make it take the form of something that's non-human, so perhaps a demonic presence. So I thought that was an interesting question, those specific questions, but also maybe thinking about the future of the software. You know, is there anything upcoming or in the future for it?
Well, thank you, Jeffrey. I think one of the challenges for designing and building these faces is that the software is actually really very flexible, and so that's a good thing. But on the other hand, it has to be operated by somebody. It has to be operated by the clinician. So at the moment we're trying to sort of two-stage approach, in which stage one is to try and cover the straightforward situations in which a face needs to be designed from a catalogue of faces plus some minor adjustments. And then there is a second stage, if that's unsatisfactory, in which we can go into change even the minutest details of a face, the width of the nose, the spacing between the eyes, and and the colour of the eyebrows and so on. So there is a sort of a basic level of adaptation, and then there is a refined level. So we can do a lot of very close tweaking to a particular face. We can even model a face on a photograph if that's required. So there is a lot of flexibility in the system. In terms of non-human faces, we have a few faces that we have managed to build which look a little bit more demonic, or like an angel or a clown. And at the moment we're just suggesting that we would have these as a a sort of repertoire of a few different non-human faces that we can use. In the previous trial, we did try looking at animal type faces as well, but in the end, I don't think these were used in the therapy. So I think we're sticking with, broadly speaking, human faces. We don't want them to be too scary, but we do have quite a lot of flexibility in terms of shape and color and hairstyle and facial texture and so on. So I'm hoping that flexibility will be satisfactory. And as I say, there is this trade-off between having enormous flexibility and making it easy to use, and we're trying to get the right point along that trajectory. Was there another part to the question I've missed?
No, I think you covered that very well. Thanks very much, Mark. So now I'll hand over to Hannah, who I think has got the next question for the panel.
Thanks, Jeffrey. So just a kind of therapy specific question here now that's come in. So does it always focus on being assertive and challenging to the voice? Often distressing voices need to be heard and understood in order for them to quieten. For example, in voice dialogue, asking what role the voice plays in the person's life, what they might be protecting the person from, and so on. So if I hand over to Tom Craig for that.
Yeah, sure. So that is really dealt with in the extended version of the therapy. So no, not everyone is anxious about their voices. Some people are very angry about their voices or respond in very angry ways, and some of the earlier sessions may there be helping the person be appropriately assertive without losing control. So there's still an element of control that is relevant to people who say they're not frightened by their voices. But the issue of the dialogic understanding of the meaning of the voice in a person's life and how they come to that is really, I suppose, the major focus of the extended sessions, the 12 session that Tom was talking about, the developing a dialogue around the meaning of the voice in the individual's life. I think you'd agree with that, Tom?
Yes, absolutely. I mean, I really agree with what the question is asking here. Avatar therapy is not seeking to be adversarial to the voice necessarily, but we're very much focused on the person developing power and control. And that might look different for different people. So every person is different, every voice is different, and that's what we try to bear in mind. And what needs to get expressed in the dialogue will vary. As Tom says, I think, that said, I mean, many people do experience feeling very powerless and kind of submissive in the face of their voice. So that's why the standardized approach is focused on that area very much, you know, with a view to it might not help for all voices, but there's enough reason to think that it could help for a number of people. And then we have that flexibility and the increased sort of complexity of delivery that's factored into the second intervention. So just echoing what you're saying, Tom, but absolutely agree. And it's a very, very good question.
Great. So I think there's we might just we'll try and squeeze in one final question, which I think will be useful for us all to maybe to think about before the end. Somebody asked, is there any danger that creating a physical embodiment of the voices could enhance any existing hallucinations or delusions by making them seem more convincing or even create new ones? So for example, if the patient begins to experience visual alongside auditory hallucinations. So I guess that might be one, again, it's a therapy related question. So maybe I could direct that to Tom Craig and Tom Ward again. And then if anybody else has any thoughts, they could jump in.
Well, the only answer I can give to that is that there have been something, if you count Julian's patients and the patients in our trial and a few people that we've also had in therapy as part of training, we've done, I suppose, a little bit over 100 people in all with AVATAR therapy, and we've had none of those experiences yet. So I say yet because it's something that we are equally concerned about, and we've been monitoring incredibly carefully in this study. Part of the reason for doing the larger study across multiple sites is to make sure we've really examined and taken taken that risk into consideration. But I am personally reassured that in 100+ cases, we've not encountered that to date. Tom?
Can I just add? I think it comes down to making sure we communicate the rationale of what the person's doing and informed consent. And I think that's crucial. And I think Susie absolutely hit the nail on the head earlier. The creation of the avatar that happens before the therapy it's not a neutral thing. It's something that people have found actually helpful. It can bring on anxiety, but the majority of people have described it as a helpful experience. Bringing something tangible that they can face. And people know their own experiences, they're having them. And so while we do monitor it, there's no indication that the avatar and the dialogue becomes unhelpfully leading into distressing experiences, more the contrary. I wonder if Susie, did you want to add anything? I mean, I've sort of just echoed what you said earlier, but is there anything you'd like to add?
Thanks, Tom. Yes, I mean, I have to caveat that with I haven't done the therapy as such. I've only interacted with the avatar for the purposes of making the video that we made. But for me, at least, it feels very much like the Wizard of Oz effect in that the voice that I hear, as I say, is amorphous. It's everywhere. I've tried everything that I could think of to get rid of it, and it doesn't go. And every time I fail to get rid of it, it dominates further. But when I say the Wizard of Oz effect, I guess it's this idea of this big, all-seeing, all-wise, smarter than me, faster than me being that lives with me. And then you pull back the curtain or you create this avatar, and suddenly it's just this small face on a screen. And suddenly it just suddenly didn't feel quite so dominant or scary anymore. It was like, is this all you are? Is that it? And that's really helped me going forward. And as I say, I haven't done the therapy, so I'd like to be very clear on that. But I felt that, I've been managing the voice in my head better because I'm now visualizing it as this small head on a screen. And that's a far less threatening thing than this all-seeing, all-consuming being that I lived with previously.
Thank you, Susie. That was a really helpful final comment from the perspective of somebody who experiences voices. And I was interested because I was just reading Julian Leff's first paper, and he talked about very much wanting to offer that by creating an image which could be external and talked to. He hoped that that would really be empowering, and so that's really helpful to hear your experience. And just to add to that point about safety, we have been taking that very, very seriously, both in the previous trial and the current trial, and we have a large structure around very carefully monitoring any possible negative effects, and we will be reviewing that really very carefully. Now I see that we've reached 16:59, and I want to thank everybody for attending and thank everybody who has taken part in this event. I think it's provided a picture of how we're working as a team to try to deliver a therapy which will be delivered remotely very often as well as in person. I hope it's answered many of your questions, and we will also be happy to follow up on further questions. I have many thanks to the people who've worked behind the scenes to organise this, and to all the speakers who have put together. I hope what you found will be a very interesting programme. So many thanks to everyone involved, and especially thank you to all of you for attending. And I hope that if you are interested in pursuing this further, you will get in touch with us and make referrals and ask questions. Thank you very much.